Okay, there's someone in the waiting room. Okay, we're ready.
Good. Okay. So welcome, everyone. I'm Nate Benjamin, Home Watch Caregivers, where you're at here today. Also ramp, wheelchair ramp, DME equipment, and fastest lab drug testing. Everyone needs pre-employment drug testing. And DNA testing. Yeah, all sorts of testing. Anyway, welcome here today. We're excited to have Horizon Home Health and Hospice come and join us. They have a new palliative care program that Peggy shared with me a few weeks back, and I think it's pretty exciting. It's been in the making for a long time. I don't want to steal your thunder, but I've known Peggy for a long time, and she was at St. Luke's doing the palliative care for many, many years, bringing that expertise over to Horizon now and introducing that program. So I'll turn it over to you. Thank you.
Well, I can't take all. So I'm Peggy Doyle. I'm the LCSW with Horizon. My role is I work in home health as well as hospice, as well as palliative care and clearly marketing. So a little dabbling in everything. Jim, come on up here. Jim. So I won't bore you with our bios because they were on the pamphlets that was also. I have had advanced palliative care training through the University of Washington. As does Jim.
Been with Horizon 17 years. And the new thread for us with the palliative care, very exciting. Also faculty with our palliative care training center at the University of Washington, helping teach serious illness conversations, and that's what we're going to bring to you a little bit today, and parts of what we do. So that's the version.
I'm Sandy. I work with Heather Crossley, the nurse practitioner on provider services, and just kind of help her and support her in all different sorts of development, whether it be clinical with her patients, the background, the paperwork, a little bit of everything. It's kind of nice. I haven't been there long. I've been there for about 7 months, but it's been fun trying to develop and help develop this new role.
And I'd just like to take a second to clarify, because our lingo gets a little confusing. Our palliative care also falls under our provider services. So we kind of use those interchangeably. So just know that we are talking about our palliative care program. And it is very exciting. This has been in the works for a very long time. We actually started in January, and we are up to 72 patients.
Wow.
That Heather sees independently, and then Jim as spiritual care and myself as social work, we go out into the community and meet our patients where they're at. That being said, when we present, we always like to start with an icebreaker, just to kind of, well, break the ice. So today's question, we'll just go around like we did with the introductions. What was your first rock concert? Monique?
I don't know if you could count music on the block, but that was my first concert. It was a big deal for me.
Yeah.
My first concert ever, and maybe it's rock concert, was Bush and No Doubt. Oh, yeah, that's way better than me.
Okay, what was your favorite?
Celine Dion.
Oh.
Did you see she's going to perform at the Olympics?
Yeah.
She is.
The
Yeah.
opening ceremony. Anyway, sorry.
I like Celine
Because she has a voice like Celine Dion.
Yeah.
Well, that.
I haven't done a rock concert. I've been to a lot of concerts, so I guess I'll do my favorite, which no judgment for this, but Taylor Swift, the Eras Tour. That was phenomenal, I'm not gonna lie. I thoroughly enjoyed that one.
Yeah.
My first was probably ZZ Top and Ranger.
Nice.
This group all shining in.
I like it.
Yeah, you, okay. I'm gonna go way back. Actually, my first concert was the Bangles. Way before they actually even hit the big time.
Really? Walk like it.
I think my favorite was Shania Twain.
Okay, I'll do two as well. So my very first one, when I was in junior high, was the Jazz.
Huh?
Oh, wow, that was good.
It was, yeah. That my favorite, I would say, was U2 in Vegas at the Dome.
Oh,
All right, I missed the introductions. I'm Sue Hepworth. I'm the Director of Clinical Services for Horizon Hospice. Probably my first one was Fleetwood Mac. We
Oh, wow.
almost didn't get to see Stevie Nicks perform for various reasons. But she did. Anyway,
The first one was actually the Beach Boys in Palm Springs when I was about 8. So still remember, I'm like, John Stamos was the drummer at the time. I'm like, I think that's the guy on that show. So that was it.
Your favorite?
Oh, my favorite. Oh, we've seen a lot. Trying to think what would you consider my favorite. You know, one that we thought was interesting was Counting Crows. We saw a couple of years, about a year ago. And what's interesting about them is I think they get bored with their songs. And they're such fantastic musicians. They just switched up the key on the song and played the whole song like impromptu in a different key. And we're like, I play guitar a little bit. My wife plays piano, and we're like, wait a second, is there something wrong with us? Like, we can barely play in the key and then just impromptu be able to switch it up. I have no idea. I don't know how you do that and remember the lyrics for like a 10-minute song. I don't know how you do that. So it's interesting.
My first was, wasn't Taylor Swift. Was Bryan Adams in Outfield. That was a good concert. And then my favorite was Carrie Underwood.
Oh, yeah,
She was awesome.
she did a great job.
Yeah.
My first concert, which rock and rolled a little bit when I was 10, and was Johnny and June.
Nice.
Carter Cash at the Illinois State Fair. And then my favorite concert, I have no idea, but I'm just gonna go with John Batiste that I saw a few weeks ago here in Boise. He was fantastic.
Well, I'm just an old coot. I don't know any of these people named. Johnny Cash, Beach Boys, 1968, Brian Wilson. And I partied with him after the concert.
Whoa.
Oh, yeah.
Oh.
My favorite group from Chicago. Anybody ever heard of them?
Oh, yeah.
Yes, they're awesome.
They are really good. Very musical.
Very excellent, yeah.
I have to agree with Sue. I saw Fleetwood Mac in concert and that was a good concert. And I recently saw George Strait and Chris Stapleton and that was a good concert.
Nice.
I'm kind of a rocker at heart. You don't always expect that from a chaplain, but one of my earliest ones was ZZ Top when they were here. That was it, and I also saw AC/DC.
No.
Yes.
They were here, so those were
We salute you
a couple of
for those about to.
good ones. Yeah.
They had a tribute band for AC/DC this last Saturday.
They're good.
And they are awesome.
They're really awesome.
They are really good.
Well, my first concert was White Tiger and White Lion. That doesn't date me, the one-hit wonders. But my absolute favorite was AC/DC, not very long after that, so. Anyway, we always like to start out with something a little casual in our presentations, just for that reason, so. We'll go ahead and get started on what our introduction is. So we are Horizon Home Health. The plan eventually will be to change our name to Horizon Health, because Horizon Home Health Hospice Provider Services and Palliative Care is a mouthful. So we actually offer 4 service lines now, which is also very exciting. Yeah, that'd be great.
Do we want chairs? Do you want to put 2 chairs up here, or do you want to stand up?
No, good. Are you good?
No, good.
So PAPC is the Center to Advance Palliative Care. And this is a nonprofit that works with the communities in promoting palliative care and the importance. So here's just a random statistic. Palliative and supportive care improves quality of life and reduces symptom distress by 66%, drives the highest satisfaction and positive patient experiences. Bringing the care that patients need where they're at. What makes us, well, I'll get there in a minute. 93% of people who receive palliative care are likely to recommend it to others. So good numbers.
That's a good question. How much do each of you know about, I know we're gonna kind of get into the differences of hospice palliative care and palliative care, but what are your experiences with just when we throw out the word palliative? I think it's a growing trend in the valley here a little bit, but any first thoughts or what comes to mind when we think of palliative?
Yeah, pre-hospice, helping out with degenerative diseases. Yeah, that where they're not qualified for hospice yet.
Think of it as that middle ground. You're here, you're not in health yet, but your next jump is hospice, so you kind of walk in that fence.
So we support people in the community with any chronic disease at any stage of that disease. So of course, hospice has the 6-month certification of terminal illness, whereas palliative care does not have that restriction. So hospice is a form of palliative care, but palliative care is not just hospice. So we have a lot of room to grow. People can still be seeking curative care, doing their cancer treatments, everything, and still be on palliative care. So that's kind of the big distinction there.
Well, that can be a huge one yeah.
That is huge.
What other type, like, you know, people think of like palliative care or hospice, they think, oh, you must have cancer, right? But what other types of diseases would you say would be appropriate for palliative care?
Any chronic disease,
So.
Heart,
lung,
COPD, you pretty much.
ALS.
Yeah.
Yeah, we support anyone and everyone with chronic disease.
Yeah, well, I'm just asking because, you know, we early onset support group through the Alzheimer's Association.
Mhm.
And there might be some comorbidities that go along, you know, as often, you know. So just kind of trying to figure out where.
Want to take this one?
So we're at the appropriate HSA team of experts, is that where we're at?
Yep.
So when we think about specialized, care and with serious illness and kind of like, I think that's a great question. Of what diagnosis do we use? And Nate's definition is kind of interesting, like pre-hospice. I'm not sure I've actually heard it termed that way. So I think that's interesting for me to kind of integrate that into, into our repertoire of what palliative care is. But I think it's important for us to remember that palliative care in its true sense is not, there's a distinction between hospice, right? So the intention, it doesn't have to be that, we bring someone on palliative care, the very serious illness, like we have a couple on right now that they're both in treatment for cancer related diagnosis. And they are not at the spot of wanting hospice, right? So although I think Nate's, definition is correct. So because sometimes that will be the transition from, palliative care to hospice. It doesn't have to be, right? So we may have someone on palliative care the entire time, they seek treatment the whole time. But we layer in, our team, which just a quick thing of us, which makes us unique, is we actually have a palliative care team. There's lots of agencies right now that have a nurse practitioner or a PA, right? And they're doing palliative care, which they are doing, I don't want to take away from that part of it. They're doing palliative care. But what makes us, like I say, unique is that, we have social work, we have spiritual care, we have MA and, Peggy and I, and soon to be our nurse practitioner, Heather, is going to be going through the program at the University of Washington as well to get her certificate in palliative care studies. So again, I think it was kind of unique that way. And I, when I hear of others with, we've got palliative care, then I always kind of think of, well, do you have a team of people, or is it a one? But I think that's a good start, right? So I think, just the idea of getting palliative care out there more and more is a great thing for people. It gives them more options.
And we've noticed a trend with several other hospices that they're using the word palliative in their care to get away from the scary hospice word. And so we, as far as we know, we are the first multidiscipline palliative care team in the valley. And that's extremely important so that we're taking care of all the needs. So.
Sorry. No, you're good. I think we kind of covered all that. Okay.
Team of experts. So what we do, providing expert recommendations and management of complex systems for patients with serious life-limiting illness, and that's it, right? That's the chronic care management. We'll see anybody with any disease process. And then, of course, with our backgrounds, on top of Heather, our nurse practitioner, which, by the way, she's on a family vacation, the only reason she's not here today. So we're really providing that well-rounded, patient-centered support for psychosocial, spiritual care, as well as medical care. So it's very much like hospice, only you don't have to have that 6 months diagnosis. And decision-making and care planning, this is a huge one.
Are you gonna talk about how they qualify to then? If it's not a hospice diagnosis, how does someone qualify to be on palliative?
They don't even need a doctor's order. They need to call Sandy. That's all. That's it. That's all.
And then, so that's a big difference, as we know, for hospice, right? You have to have an order to become on hospice services because of the 6 month or less Medicare requirement for that.
So is it covered by most insurance and
Yes.
Medicare?
Most insurances, yes. Medicare, Medicaid, and some of them do have a copay, but we'll always know that before we go in, so we can already warn them that that will be there. But more often than not, I'm not seeing copays. Are you, Sandy?
So then if you don't require a doctor's order, then you just request medical records to confirm.
Sandy has access to all the medical records and Epic and all of that, so she can research all that information and get that built into our system, and then calls and makes our appointments for us. Well, for Heather. We don't make her do it for us.
So what area are you providing?
Excellent question. Right now, we are limiting geographically to the Boise Meridian areas. We do have a couple of little outliers who have moved recently, but our other branch is west, which is Caldwell, Emmett, and Fruitland. And I know that they're working on developing their program. We just happen to be a few steps ahead. So that's an excellent question. For the most part, it's really just in town here.
And it's still a learning process for us, right? So even though I've done hospice for 19 years, and I started doing this more of the palliative care approach and going through that training just like 4 years ago, our team is still, kind of getting our legs underneath us of what that looks like for care, too, and how we approach it.
So quick question, I am not sure, do you want to be peppered with questions right now, or?
That's fine.
Okay.
We're pretty casual.
Yeah, I'm just curious, what does the actual, is there a real distinction between the type of service that you're coming out and doing versus the hospice in terms of hours and what you're providing, or is there really no distinction between the two? It's just the name.
The main distinction is when somebody is on our hospice services, they typically have a nurse visit 2 to 3 times a week. If they're imminent, it's daily. Social work is typically 2 times a month. Chaplain.
Yep, it's anywhere from on hospice from once a week to once a month, if they want to see us.
Where we are now with palliative care and provider services is Heather seeing most of her patients once a month. And then we come in when there are outstanding needs. Okay, so we have our own palliative care interdisciplinary group meeting every other week. We discuss every patient, how they're doing, what their needs are, and what's the best fit for one or the other of us to go out and do this goals of care
Cool.
conversation.
And I think another big distinction is, and when we think about levels of care, you know, as kind of hospice being, you know, the most intensive part, right? That we also fold in, that we let them know, you know, then we can add in bereavement services. And we can add in the CNA services. So there's additional things that we can fold in with hospice. So it's like switching from home health, right, to hospice, you know, the transitions there and the differences there. And then we can kind of say with palliative care, you know, we can do a lot of the spiritual, psychosocial things that hospice is doing. But there's still more that we can add in with hospice.
And just to add in on that before I forget, sorry, Sue, we can be doing home health and palliative at the same time. Okay, so we can have that dual role in there. And we do a lot of monitoring with our home health team. Who do you see might be getting close? How could they use extra cares? So that's a whole other meeting that we have on Wednesdays. So we're really looking at the big picture to make sure that our patients are getting the right service line at the right time.
Sounds like you provide kind of a continuum of care as
Right.
their progression, as the disease progresses and their care needs increase.
One of the, oh, go ahead, Sue, sorry.
I was just gonna say, one thing that you guys talk a lot about is having goals of care discussions. And sometimes those goals change when it's palliative care or the hospice. And with their training and their expertise, sometimes patients don't recognize that their goal doesn't always match up with the treatment that they're seeking. And when they have those discussions, they kind of realize that they don't really have to have the treatments to get to their goals, and that maybe their goals could be better met with some extra help with hospice. I think too that the focus of social work and chaplain changes too when it comes into hospice care. Then we start focusing on end of life and dynamics possibly that arise in the family, things that might not be there in a palliative setting. And palliative is in conjunction with possibly they have another provider. They don't have to give up that other provider. We're not coming in and taking over the care. We're in addition to them, just like a specialty of cancer, oncology, that type of thing. And if they have a good relationship and are seeking to continue with that provider, then they're in communication with things that they've seen or changes in medication or things like that with the provider that was in place.
And Heather's role as our nurse practitioner, she can either be a specialist consultant or she can take over as primary. So for example, when we have a homebound patient who's really struggling to get to their medical appointments, we can step in and provide that service in the home as that extra layer of support and report back to that physician. We don't want anybody to think that we are coming in to take over. You know, we've seen that happen in a lot of the facilities. We're not. That is not what we're gonna do. I don't want to take a little 90-year-old lady away from a PCP she's seen for 50 years. But I do want to help support her with decision-making and planning. Like, what is your long-term goal? Do you want to go back to the hospital? If it's broke, do you want us to fix it? You know, that sort of thing.
Yeah, a lot of the doctors just aren't really skilled at making those decisions anyway. They're really
Well,
not.
and it's hard to do that in a 15-minute blood pressure check.
Yeah.
The one thing that we have to offer more than anything is time and conversation. So.
That we can hopefully, you know, go into these more in depth when we talk about what's important. You know, we've heard those conversations, those of us, and then, you know, what's most important to you right now? And then try to align with, you know, what's going on, and really processing with the person, if they allow us to go there. It's not, you know, like we come in and here's what we're going to talk about today. It's more of, you know, again, trying to fold in some more options for them, because we know that, and just kind of the part of I guess, a little plug for, you know, what University of Washington and other educational arenas are trying to provide with palliative care is they're really trying to reach physicians, right? So that's a huge component, and all of us know, been in this a bit, that when we have a physician on board of being able to have, that's the person that really should have that conversation about where they're at. but we know that that's not always happening.
Should.
Right, should. And so part of that whole idea is that we're trying to move that conversation further upstream to the physicians of all different levels. So when they're in those spots with their clients, that they feel more comfortable of having those serious illness conversations with people. And I've been in these training simulations with physicians. It's almost like the light bulb coming on because, and how many of us, when as clinicians, when we go into a visit, we oftentimes want to just jump into our little bag of what we do instead of seeing where that patient wants to take us and what's important to them first. Addressing emotion, what's going on, you know, when they're coming to us of like, I just got diagnosed with, you know, XYZ, that we just don't say, oh yeah, well, we're gonna do. And said we spend time with them, validating, you know, all those kinds of things social workers, chaplains love to do, right? Validation and, you know.
I can add, physicians are problem focused.
Yes,
They're
Yeah.
looking at fixing a disease or risk. They don't look at the bigger scope. Right, which is where a lot of the rest of us come in to look at that whole person. What else is, what are the other dynamics?
And I would say, and in fairness, you know, think of our physicians, they've been tasked now a lot to in their clinics to have 20-minute, you know, like 20-minute visit. How much can we really get into goal planning and what's important to people in 20 minutes? They're moving people through. And so, and in their fairness, they are very limited of what, you know, time-wise, just alone, what they're going to be able to provide. So the whole idea is trying to move these conversations further upstream, you know, with
Good luck.
yeah, it's
one of,
it's gaining progress.
It is.
I can tell you,
It's an
it is,
insurance
it is.
it is.
financially compensated.
The whole first quarter of the University of Washington program is based on a program called Vital Talk. And if you don't have the app, download it to your phone.
Vital, okay.
Yeah, it's Vital Talk Tips. This is a program created by the University of California, San Francisco to teach doctors how to speak English.
Does it teach me how to write in English?
No, that doesn't go along with it. But I've been doing this for a lot of years, right? I've done hospice, I've done other medical social work. I learned so much in that first semester, and I still get to use those tips and tricks every day. And it really has expanded my knowledge for how to talk with people and do that rapport building.
Yep.
And you know, I'm a social worker, I can chat forever. So if you want to give us another one, Dave. So we already kind of covered this. Why are we different versus the other agencies out there calling themselves palliative care? Because we have our multiple discipline team, we do coordination of care with every patient. Heather Crosley, of course, Jim, me, and Sandy. This is our interdisciplinary approach. Any questions on that? Okay.
I think, you know, when, you know, like, well, why would it be important? You know, so, you know, when we're with our patients and our clients that we see, you know, reasons to consider palliative care. Really, it's one of the whole big things and definitions that we work with when we go through the program is, you know, at its core, we're trying to add another layer of support for people. Really, it's kind of at its core. Whatever the illness is. And there are some, I think, models that will say like timeframes for palliative care. In our teaching, we don't mention times at all. Like, you know, it's a person within a year of death or, you know, 2 years. That's not really even something that we, you know, like focus on. It's more of that serious illness. You know, what is it? Is it chronic serious illness, things that we're working through? Again, it's symptom management. It's working with their current physicians. Like Peggy said, we're not there to you know, say, hey, we're coming in, get rid of your PCP. That's totally not what we do. Another thing for the home health side of it and is to try to reduce those admissions to the ED. You know, if we can take and help care for people instead of having to go to the, you know, to the emergency room or just emergency department, keep them out of the hospital and this whole circuit of, you know, that we all know of how that works on people are this rotating door. And a lot of times we can help manage that in a way that we're reducing that, which helps everyone, right? I mean, if we can hopefully keep people out of the hospital for something very simple that, you know, our physician can help with in the home, that's huge.
And there have been, be right with you, there have been any number of times that we're discussing our patients in IDG, in our IDG, when Heather had to make an emergency run for an antibiotic, and we kept that patient out of the hospital with UTI. We've been very successful in doing it, and that is our end goal. Just, he had a question first. Yeah.
Oh, I should know this, but what are refractory symptoms?
Refractory symptoms, that's really getting to the goal of, what's really wrong? You know, what is it, the disease course, or are you having other symptoms that we can kind of tease out?
Does that include like medication interactions and medication side effects? Or secondary, something that happens as a result, so you have a UTI and suddenly you have now a kidney problem because it's gone upstream, literally. What do you do in the way of respite for caregivers, bath aids?
That's where I come in with resources. And I will refer to outside personal care service agencies. We don't have any coverage for PCS at this point. We also, we have one patient on our services right now whose wife checked him into Valley View for respite, and we're like, what, where's our patient? So, you know, we do what we can, but of course, as you all probably know in this community, finding a respite bed, getting a respite bed, close to impossible. And then if it's Medicaid on top of that, it is impossible.
It is impossible, and then you add any psychosis and you're really done.
Yeah.
Well, no, that's a good question. So I think that's again, one of the things that separates our palliative care and a hospice team, right? So there are some major differences that we're gonna fold in with hospice care that we just don't have the resources and able to do on the palliative, right? So truly the team that we have is, you know, and then we like, you know, social workers are always our great resource people, right? Finding these resources in the community. And then that's where, you know, Peggy jumps in and tries to, you know, share this out and with our
Do
community.
you have a volunteer pool?
We do not. That's one of the hospice benefits, right?
Yep.
So when
Yep.
we're in talking about bath aid, respite, any of those kinds of things, those are hospice only because that part of that hospice benefit.
Medicare.
Yeah.
covers all that.
Yeah.
Dini, thank you.
And DME. Yeah, so there's, I think those are the, and thanks for that, because I think that's some key
Areas to
differences,
expand.
right?
Yeah.
And that probably most palliative care teams are not going to be able to expand into those areas.
Right.
That will still be in the, you know, kind of the area for hospice care,
And
right?
maybe
So,
that's, you get to a point where that's when you start moving into your hospice.
Well, I think that's.
Right.
It's because-
Palliative too, is
Yeah.
it helps prepare patients and their families for that transition to hospice at a time that's more
Yeah.
appropriate versus like,
Versus
we're in
early.
crisis now, we're towards the end.
24,
Like,
72
never
hours.
have fun.
Yeah.
Never. This way it's a severe.
And education. Education is key to what we get to do. So it's, I did have another point, but I lost it already. Sue, did you still have a question?
I had a couple of comments. So the hospice benefit, expands and the thought behind the respite and the DMEs is that, the reimbursement is there to cover those things by hospice, which it's not there for palliative care.
Right.
And there's, I mean, for that reason, because our reimbursement's not as great, I mean, we're lucky we break even with palliative care programs, and versus hospice. And still with all the demands that hospice has, is when the margins are getting narrower and narrower. But, on that note, that you talked about keeping patients out of the hospital, we also provide, 24/7 access to, so they have an after-hour, number that they can call if they need us. If that palliative patient is accessing that a lot, that's also, kind of a red flag of there's some decline going on, something's different. We haven't seen that a lot yet. We've just had a couple, 3 calls come in so far. But, that's also another backup of trying to keep them in their own home like they want. And also us recognizing that maybe there's a decline that has happened since we last saw them. So.
And just as a reminder, we did just start this in January, so we are very much in our infancy and growing fast. So it's very exciting, but it's also slightly daunting.
Yeah.
We have a certain facility that wants us to start seeing all of their patients and then following them home after a short rehab stay.
Is that a rehab?
So,
Is that nearby?
Yeah,
One
no, yeah, it's yeah, actually, so, we've been talking about, palliative and its utilization in the hospital systems, and it's been a little bit less as time has gone by, and they're not very well supported in the hospital systems anymore where patients
No.
are in med advantage, especially in the med advantage plans, because you got
That's right.
patients that are being paid, patient stays are being paid on the DRG and not overnights, and palliative consults will come in and oftentimes delay a discharge by a couple of days, because
They
you
don't
don't
want you doing that. They do not want you
Hospitals
doing
don't
it.
like that, you know, the hospital system doesn't like that, and oftentimes, especially if the goal is to just be able to go back home and toilet themselves or do a little bit more functionally, you know, they'll opt for rehab and then opt out of palliative services. And, you know, they don't have the option presented to them at the hospital, or they think that they're not ready for it yet, because this is like, well, no, I'm gonna go to rehab. And, you know, in rehab, we don't talk about palliative. We have an MD who spends, you know, 10 minutes doing a face-to-face, just going over the review of systems and what we're doing to address all the problems, fixing problems. And we're not doing these goals of care conversations. And so it was kind of my idea in talking with Horizon to see if we could get their provider, Heather, to come in and start billing Part B, and having Peggy doing, and Jim doing visits in tandem.
Building a relationship, yeah.
Yes, and I think if we can get a palliative consult done, you know, at the hospital, it's kind of rushed. And they're still trying to push you out the door, and you have a family faced with all of these, you know, swimming with all of these decisions to make, and the hospital saying, hurry and make a decision. If they come to rehab, they're not gonna be hurried. You know, the referral will be sent to Horizon and to us about the same time, so that when they come to us, Horizon's already aware of them, and come in and do a visit with the family. And then they've got, you know, 2 weeks longer at Shaw to kind of think things over and decide what they want to do. And so
Be nice if you could rebrand the name. Hospice, palliative, if you could merge those two and rebrand them so that it's a more positive.
yeah,
It would be so much easier.
yeah. I think it's gonna take some finessing with, you know, not just patients and families, but also even case managers at the hospital, you know,
Everybody.
it's just not something that they readily go towards. So if they've got life-limiting illness, I mean, that's one of the things that I do when I'm looking at patients' intake paperwork, you know, I'm looking at all their diagnostics and spending enough time in hospice myself before I came here, I'm able to kind of weed through and see what's going on, and if they haven't had a palliative consult, I'll be able to ask the case manager, can you please order a palliative consult if you're not gonna do one here at the hospital, and let's do it at Shaw. And that's been, I mean, so far, the idea has taken root significantly with nurse navigators and with MDs, both at St. Luke's and the St. Al's palliative system. We were thinking initially that we might use the hospital system to come in and be, you know, an extension of the hospital at Shaw, but their bandwidth is very limited, and we obviously know and love Horizon very much.
So are you thinking just those that come in for rehab and then leave, or the long-term care?
But so they'll eventually, I would like to also see them doing consults on long-term care patients. Initially, the idea is to have the patients visited in the rehab setting. It should happen that the MD in our building who rounds on all the long-term care patients will see that we're approaching hospice appropriately and having conversations, but they don't always happen, or they do, but they happen really late. And so by the time they come in and see a patient for hospice, they are living 2 days. We don't want that. So eventually we're gonna expand into the long-term care
You need
unit.
to. Having
Well,
seen
well,
the
sure.
levels of care and how they vary from community to community, that would be a huge quality care.
Yeah, Yeah, I think we wanna start with rehab, and long-term care is really difficult for, especially for, there's a lot of SNFs in the valley who don't let hospice in. Because there are a lot, there's for many reasons, one of them, there's a liability to the building because their documentation has to match the building's documentation. And then there's something called case mix index, if there's buildings wanna have a higher case mix index, they wanna have patients with a large number of comorbidities so that their Medicaid reimbursement will stay strong. And patients who are on hospice completely drop off your ceiling and they don't count. And those are really sick patients. And so the SNF likes to recoup the. And so the hospice is hard, and it's kind of a bad word in the skilled nursing facility setting, unfortunately.
This is a big conversation right now out there with, it's being lobbied to try and get that. Yeah, the whole idea was Medicare wanted the states to share some of this cost, and so that's how it kind of all came about, but it's almost like it's, denying the patient their hospice benefit because they can't afford to not have those days in that case mix, and it's not really their fault, but it's a decision that they financially are looking at making because of the reimbursement issue.
I think one of the things that is core, if we think about palliative care and kind of the training that we go through to have these conversations, it's trying to find the right spot for the person at the right time, right? Knowing that it's this fluent thing. This is not a static, type of thing. So they might start on a home health service, then we fold in palliative care, and then, maybe there's hospice, but I think it's finding that further upstream, like I said before, if we can get the people into the right spots sooner. Because like Monique has just said, one of the things that's difficult is when we get referrals on the hospice side, right at the end, a few days left of life. So the hospice teams can't kind of do what they're trained to do and help families prepare for the death, work on anticipatory grieving, getting referred out to, either guardian sometimes or elder law, people getting their things in order, basically, if we had more time to do that. So it's trying to moving that dial further up so we get people where we can help them more for a longer period of time.
There's that triggers. What are the criteria to entering?
Again, doesn't even need
There's
to
no,
chronic illness at any stage of that disease.
okay.
Well, I can share a story of a family member of mine, so I have permission to share the story, 'cause I think it helps paint the picture, and I shared this last week at our palliative care presentation at the IHCA conference. So a couple of years ago, my grandparents, they lived up in Lowman, up in the mountains, and they lived there for like 20 years, and sadly, their cabin burnt down to the ground, and they lost everything in this fire, and moved back to Boise, and were living in a temporary rental while they were figuring out the homeowner's insurance and everything, and my grandpa was having some like incontinence issues and just some new things going on that we thought were maybe stress related or whatnot. And anyway, he went and made an appointment with his urologist, and it was discovered that he had bladder cancer. And his primary care provider was still up in Logan, and the urologist was like, well, I can provide you with surgical treatment options, but that's all the options I'm gonna offer you. If you want poison options, it's literally said, I can refer you to an oncologist, and you can get options for radiation and chemotherapy, and then back to your primary care provider for just management of symptoms and whatnot. And so it's like, holy cow, his whole world has now been flipped upside down. They lost their home. He's got this new serious diagnosis. He's presented now with different options. He did go to consult oncology, and now he's presented with all these treatment options, and he's kind of stuck like, what do I do? Like, do I go the route of surgical and have my entire bladder removed? And what does that look like for me long term? And will it rid me of this cancer, or do I go this other route? And so we pulled in Dr. Walker, who's still our medical director at Verizon at the time, was doing palliative care, and got him involved, and our home health team involved too, to kind of manage these new symptoms. And what he did was really helpful. Again, you don't need a referral. It's billed just like a subspecialist of medicine, just like you would see your cardiologist or your urologist or whoever else you're going to see a specialist related to palliative care that can kind of sit down, talk with the other providers now involved in his care, and figure out what matters most to you. Like Jim has said, like, what does this look like if your bladder is removed? Is this something that you can manage? Can you manage go in for stints and all these things, you're gonna have to be doing
Care
there.
coordination.
All the care coordination, can my grandma, his caregiver, help manage that and support that? There's all these conversations that need to be had, but the medical provider, Dr. Walker, was kind of able to say, here's what this would look like from a medical perspective, depending which route you go down. And that really allowed them to then make the decision about what treatments they would navigate first. Because it's kind of hard to weigh out all those different options from all the different medical providers and figure out what the best options are for care based on what matters to him. And so I think it's a good example to share, just because you can probably think of all the different patients we've had, they're presented with all these different options, and it's like, what do we do? So I think the goal of palliative care is to take someone at that time of serious diagnosis or chronic disease or life-limiting illness, like Monique said, and figure out what route do we go from here, and allow them to have all the education so that they can feel like now they're able to make a better informed decision.
We do have an additional case study on one of these
Perfect.
lines.
Yeah.
So again, communication, symptom management. Thus far, we have not really been challenged with pain medications. And Heather is walking a very fine line with that, because we don't want to be working with chronic pain medications. That needs to stay with the primary provider. Complex decision-making, prognostication, psychosocial and emotional support, community resources, spiritual support. Didn't add that one, sorry, Jim. So if you want to hit the next one. So these are kind of the care models, right? The old one, life prolonging care, that aggressive treat, boom, hospice, right? Whereas today, our attitude has really changed, where we have the life prolonging care. At the same time, we have palliative care. So we can have those discussions and have that advanced care planning in place so that we know what they want.
You have an arrow going both directions.
So this is a very busy slide, but supportive palliative care, hospice care, and the things in common: optimizing comfort, reducing stress, relieve symptoms, providing that emotional and spiritual support. So this is my case study. This was a patient of mine, loved her very much. 60-year-old female being seen on palliative outpatient clinic for chronic pain syndrome, opioid dependence, continued chronic pulmonary aspiration. Patient has a history of COPD and STEMI, dysphagia, diabetes 2, CKD, AKI, anxiety, depression, multiple pneumonias with hypoxia, obesity, among many others. Okay. She comes into our clinic. We meet with her and her husband. The year prior to establishing care with our clinic, she was hospitalized 7 times. 4 of those were ICU level intubations. She was relatively younger. She was only in her 60s. 20 months being followed in the palliative care outpatient setting. During that time, 0 hospitalizations. We managed her shortness of breath with morphine. We managed her other symptoms, and we had those conversations with her and her husband. 1 hospitalization was her end of life event, and it was COVID. She was already so compromised. So if you want to. So again, we provided the natural history, or the progression of the disease, provided that emotional support, clarified the goals of care and advanced directives. She had nothing prior to seeing us. Opioids for dyspnea, treatment of exacerbations at home. We were able to monitor at home. She could call us in and say, hey, call the prescription, so we didn't have to rotate back into the hospital. She was eventually admitted and required BiPAP. Family knowing patient wishes, opted for comfort care in the ICU, where she did pass. Then I was also able to follow up with the husband and provide bereavement support. So this is my favorite slide. Instead of 7 more hospitalizations, the patient was able to celebrate 7 more grandbaby birthdays, which was her priority to goals of care. Life-changing service. This is just an article from about ALS and the importance of palliative care working within ALS. We all know what a devastating disease that is. So I'm gonna have to read all that. It's all pretty wordy. Yeah. Continue. Dr. Heidi Orm is an ALS specialist here in town. This is her quote. "You have been an invaluable resource for me and my patients." Because again, she doesn't have time to have those goals of care conversation and advanced directives in her every 3-month clinic.
What was her last name?
Doyle. Oh, Heidi Orm.
I think that's about as sentimental as she gets, those are all, I mean, that was outstanding.
Yes.
They're important, yes.
So here are some additional resources. CAPC I've already mentioned, Vital Talk Tips I've already mentioned, and the Fast Facts app can be very beneficial.
And so some of these, things we piggybacked on from the, give kind of some credit to the Palliative Care Training Center at the University of Washington for some of these concepts and things that we've talked about. But
Which campus?
Seattle.
well,
Online.
when I started, they were still, again, this was right 1920 when I got involved with the program. And they were still having it in person at the campus there in Seattle. In COVID, we went completely Zoom, which we found out we could do, and the amazing people behind the scenes that have helped us. Then since then, it's all been virtual. I mean, we'll have in that program, oh gosh, we've had 60 some students all on Zoom. And it's a very complicated system. They've been able to get it figured out how we can do simulated learning, and we put people in role play, right? Everybody loves role play, but it's such a good learning tool.
Awesome.
It
Yes.
is. We call it the hot seat.
Yeah, the hot seat.
Hot seat.
But we learned so much from that. And another component I was gonna piggyback on one of those slides was, and I was relaying this to a family I met with yesterday, that we can help have conversations with their physicians. Like, so we could go with them to one of their specialists and kind of play good cop, bad cop in a sense of asking questions or, well, doc, like one of the techniques that we use, because doctors oftentimes don't want to say, like you have a certain amount of time, right? They don't want to give the time. So one of the techniques is saying, okay, what would you say our best case scenario is in this case with this family? Then they're able to, and they're more, that's not a bad question. They can, navigate that one. What's our worst case? What do you think if, and then what's our most likely? So when we frame it that way, again, part of this whole process of palliative care is the language that we use. And we're very intentional about different language that we use when we're trying to navigate these discussions and building blocks of getting people to open up, addressing emotion first, all these different things. But I guess that main part of that was that we can meet with their docs too, to help them have these conversations. And when I've been able to do that, even before the palliative care, when we can meet with the doc and have, kind of be the go-between, it helps the doctor feel more at ease because they're not having to say some of the things with, or they can say it, but not say it. And then the family's more informed. So it really does make a big difference.
Maybe to support them.
Exactly. Yep.
Mhm.
Yep.
Good, thank you.
Any other questions, concerns, comments, feedback?
Well, that's perfect because our time is up.
Do you think Jim and I have done this a time or two?
Pretty good.
There's lots of good questions, and if you have more or want to reach out to us, if you have something that you didn't think of, please let us know. Or maybe in your particular agency that you're with, if you want something more specific that we could bring in, let us know.
So again, Peggy and Chaplain Jim You can always get us through the Horizon main number. We're always tethered. Try to have